Hello everyone, welcome to this new episode of Pathophysiology Stories, a new podcast by Connect. For those of you that still do not know us, we are a newborn association founded by the former Colony Group, and this was done in order to foster networking among physiology enthusiasts. With this podcast, we want to rediscover the stories behind how the modern intensive care developed, thanks to the curiosity and passion for understanding the underlying mechanisms of diseases. I'm Irene Steinberg, and I'm here today with my colleague Mattia Busana.
Hello, good afternoon, everyone. Yes, of course, I'm Mattia Busana, and today we have as a guest Professor Roberto Fumagalli from Milan. Professor Roberto Fumagalli is a worldwide known expert for intensive care medicine, and has long been ordinary professor in Milan. And today we are going to discuss with him something that for me is particularly important, interesting. It was, let's say, the beginning of my interest for intensive care, namely the baby lung, and let's say a journey from the discovery to the current clinical implications. Professor Fumagalli, welcome.
Thank you, Mattia. Thank you for the invitation. Let's say that for me it's a privilege to speak with your group, because I always heard from Luciano you are very attitude to curiosity and to work. That are the two main features that can make people a scientist. So, as you said, I must say that I was there when the baby lung was discovered. But let me just give you an idea how was the humus in Milan when we arrived to the baby lung concept. Let's say that critical care was a quite young specialty. Its roots came from anesthesia. And I think that we had the fortune that our boss was an anesthesiologist, but who was very prompt to teach physiology. And let's say the homeostasis was one of the points he was always doing in his anesthesia. So to understand homeostasis, you must know very well physiology. And I think for this reason, he wanted to work with people like Gaetano Iapichino, Luciano Gattinoni, Martin Langer, and others. So, and his name was Professor Giorgio Damia. And he was curious too. And let's say in the 80s, at the beginning of the 80s, inside the department, we had our own library that, right now for you, having the the chance to deal with the internet. It's so easy to find out articles so on, but at that time it was not so easy. And moreover, we had our own journal that was named Anestesia e Rianimazione. It was an Italian journal, and it was a peer review, and he really wanted us to write papers on that journal. But let me make this story a little bit shorter. Let's say that when I arrived as a student in the ICU, it was called Emma Becra, Professor Luciano Gattinoni was arrived back from United States a couple of years earlier, and he was dealing with extracorporeal circulation. At the NIH, Professor Gattinoni met another very curious man, a real scientist. His name is Theodor Kolobov. Those two persons were able to develop, just sharing the same idea, a concept of resting the lung. What do I mean? They were thinking that the way how the people was dealing with respiratory failure was wrong. Basically, they succeeded in the lab in providing all the gas exchange they needed without the need of a ventilator. I mean, they succeeded in just removing all the CO2 produced by the animal and providing some oxygen to the lung of the animal. And in this way, they were able to keep the animal alive without any burden of the ventilation. In fact, they got the feeling that the way how at that time people were treating respiratory failure could be dangerous. After this period of experimental practice, Luciano came back to Italy and he tried to apply this technique to humans. At the same time, in the United States, they were just finishing a randomized control study using extracorporeal circulation to treat ARDS. And the mortality in that study was near 90%. With the technique that Professor Gattinoni applied in the first series of patients we had in Milan, the results were completely different. And at this time, the idea that mechanical ventilation could be very dangerous just started to grow up. At the same time, a little bit later, Professor Antonio Pesenti went to NIH and in a model of neonatal hyaline disease. That's a sort of respiratory insufficiency of the neonates. He succeeded in showing that if you are not going to provide ventilation, the disease is not going to develop. Later on, I went to the NIH and we were able to show that if you are treating normal lungs with high pressure, in 8 hours you are going to have a severely damaged lungs. We published this article in 1985. In the meantime, Didier Dreyfus published the same observation in rats. In 1984, another Italian doctor coming from the Luciano unit went there and just producing artificially high volume ventilation, spontaneous, just injecting in the cisterna magna salicylate acid. He succeeded in having lung damage.
Thank you, Professor. If I can ask, because I think Mattia and I were from a generation that, I mean, we were raised with the mantra, if you may, that you should ventilate with 6 ml for kilo. But I think that in those years, the paradigm for RDS management were really, really different. Can you maybe just explain it a little bit for our listener?
Yeah, you are right. I'm sorry not having to represent the whole picture in the complete way. You are right. In fact, the paradigm over there at that time was just to keep a normal oxygenation and normal CO2 removal. How did they succeed in doing that? Just having high tidal volume ventilation with high pressure. In one paper, the first one illustrating the beneficial effect of extracorporeal circulation, there is the entire description of how they ventilated that patient. It's a single patient, and it was published in the New England Journal of Medicine by Hale. The peak pressure used was 65 centimeters of water, and the tidal volume was 1,000 milliliters. In that time, let's say between 70 and 80, the main goal of the clinician was to keep oxygen level physiologic and to get rid of the CO2 no matter on the pressure and the tidal ventilation. And in fact, the pneumothorax was a quite frequent problem. Let's say that in the randomized control study, 47% of patients got pneumothorax.
And Professor Fumagalli here, you know what, I spoke a lot with Professor Gattinoni about this topic, and he told me that you were basically putting preemptively chest drainages to those patients, so that in the case that they would develop pneumothorax, they would be already treated, let's say. Is it correct, right?
Basically, let's say that at the time I arrived in Milan, we were just doing a more gentle treatment. So we did not use in a preventive way, but in US, around the years nearby 80, in some places they used to put a preventive chest tube. But let me make another point. The fact that pressure and volume was not such important, you can get from the publication of that period. You are going to find out a quite nice article where there are no reports on airway pressure and tidal ventilation during ARDS. Just because the only paradigm was to keep oxygen and CO2 at the normal level.
But people were, tell me if I'm correct, but people were well aware that the pressures required were much higher than a normal man requires. And so everyone was saying that the ARDS lung is stiff, correct. And so I think that is, I mean, I think some of us already heard this kind of story, but it would be really interesting for us to know, again, to speak about what led us to understand that the lung, instead of being stiff, is actually small. So to the idea, how did we came to the idea of baby lung?
In fact, as you were saying, our attention basically was dedicated to the chest X-ray that was showing a uniform distribution of the opacities and to lung compliance. Just because lung compliance was low, clinicians thought that the good thing to do was to try to win the stiffness of the lungs. Just because the thought at the time was that the disease was very diffuse. Let's say that it was an intuition of Luciano and also of Antonio Pesenti that they wanted to have a group of scientists able to exchange ideas, just joining a couple of times per year. So people there were Conrad Falke, François Lemaire, Vespril, and one of those was Conrad Edestierna. He is a physiologist. He was a physiologist working in Uppsala. And during one of those meetings, he illustrated the CT scan of patients after the anesthesia induction, where some densities are appearing in the dependent region. When Professor Gattinoni saw that behavior, asked the permission to Goran Destierna to use the technique, just getting the idea of Goran, in ARDS. Till that time, CT scan was used really rarely. Maybe there are a couple of publications. The CT scan, it was used for pulmonary embolism, for other things, but not to study ARDS. The first time when we did it, we realized that what we thought it was diffuse, it was not diffuse, and it was the pathological process was very inhomogeneous. So we had some area that appeared normal, in some areas completely diseased. So at this point, it was possible to divide the lungs in well ventilated, poorly ventilated, and consolidated. But in this way, we realized that the amount of lungs accepting our tidal volume was much lower than the entire lung. And the other point, very important, was that the compliance was related to the amount of, let's say, healthy lung. It was later on we decided that we discovered that it is not healthy, but it was aerated lungs, and so it means that the volume we provide to the patient, the whole volume goes in the small aerated lung. So we are determining an hyperventilation. We are doing what in the experimental lab at the NIH some years before we did. And that was called at that point baby lung, because it's the size of the lung is the size of a 5-6 years old boy. It depends, sometimes less than that.
Thank you, Professor. So I guess we can say that looking at CT scan was in some way decisive to get to the intuition of the baby lung. But can I ask you, how was this received by the scientific community? Because as you were saying, the paradigm for management of RDS were completely different, and you were presenting with a completely new idea based on an imaging technique that was not applied to the lung yet. So this was something completely new, I think we can say.
Let's say that the demonstration of the inhomogeneity was quite evident. Later on, we also had the chance to show how the morphology of the lung was changing according to the PEEP applied. So we had the chance, and we demonstrate it, that the effect of the PEEP on the oxygenation was basically due to the increase of the amount of ventilated lung. And in one editorial by Warren Zappel, we were very proud because we had been compared to Vesalius and to Leonardo da Vinci, because we had been able to show directly the effect of the ventilatory therapy. So from this point of view, it was accepted because we demonstrated it. It was a little bit, not a little bit, but it was different to convince people of the effect of the prone position. But this is another story.
But Professor, I think that in general, also this together with the story of prone position, I think that highlights in general the fact that in those years it was basically physiology first, and then the change of treatment just followed, let's say, the understanding of physiology that we were gaining through smaller studies, let's say like that. So can I ask you how this better physiological understanding of the lung that is smaller instead of stiffer, and also probably also all the findings regarding the proposition, how did they change the way we managed, you managed back then the ARDS? Of course, I guess that no more preventive thorax drainage, but in general, how did we change the way we treat ARDS patients?
Exactly. Applying the physiology make you think to the problem in different way. So if a baby breathes with lower tidal and higher frequency, then we have to move toward this way. We try to make much more physiologic approach to the disease, just because anyway we saw that if we apply the same tidal volume we apply to a normal lung, if we apply it to a smaller portion of lung, to a smaller FRC, we are going to hyperinflate, we are going to hyperventilate, and at the very end we had shown that hyperventilation was damaging the lungs. And that changed completely the mind of clinician, and justified much more the use of different tools useful to avoid hyperventilation. Let's say that extracorporeal circulation, let's say the echo was basically much more justified by the baby lung, just because otherwise, I mean, two things had been justified: permissive hypercapnia when possible, and the other one, the earlier use of CO2 removal.
Very well. So you basically mean that people actually understood that maintaining a normal gas exchange in a patient that has a sick lung, it has a cost in general, and maybe we can tolerate suboptimal gas exchange, but the lung needs to be preserved, right?
Right. In fact, I think that this is a sort of philosophy in medicine that, for example, it was applied by cardiologists. You know, at the beginning, in order to get a normal cardiac output, cardiologists used to give inotropes, but at a certain point they decided to give vasodilators. It means just because instead of push the heart to pump, you can relieve some work having a decreased resistances. At the same way, if you can, it's a sort of arresting the heart. And what Luciano taught us is that if the lungs are diseased, then maybe they must rest. We don't have to push them, and we have to accept maybe some lower oxygen, higher carbon dioxide, and if it is not possible, we can use some extracorporeal tools in order to get this kind of results.
Thank you, Professor. I think I can steal Mattia's word in saying that the better is always an enemy to the good. And with this, I would also like to ask you, because I mean, today we were talking about how an idea came to you, because you looked at the physiology, you looked at the imaging, and you did something to test your idea. So do you think that the way we conduct research today, has it changed? Do we sometimes maybe it's just a gut feeling, but we're not always just starting from physiology. But what do you think about it?
I think that doing research right nowadays is more difficult than once. For sure, if like Professor Gattignoni used to say, we must look at the problem with the child eyes, and you should try to make things very simple at the beginning. Later on, maybe in order to understand deeply, you can complicate your reasoning, but at the beginning, you must observe, you must know physiology and observe what the patient is showing you. Now, the chance to have experimental place where to study, where to make trials, in our experience, was really very, very, very important. And I think that you observe the patient and maybe you get the idea. You develop the idea in the experimental lab. You test it and then you come back to the patient. If you do in this way, this is, I think, the best way to do research, but it is not so easy, first. And the second point is that actually many times you need a huge number of patients in order to show something. And because of the heterogeneity of our population, many times we are not able to get the answer. Many times the studies we did not show, despite the fact that the rationale was very consistent, but at the very end, we did not succeed in showing the results. So one of the things that we should try to do is to find out, maybe through phenotyping, genotyping, whatever you want, to have a more homogeneous population where you can get the signal of what you are doing in a very clear way. I know that's difficult, but I think that this is one of the future aim of research.
Thank you very much. You mean in general then that physiology, let's say, is still there, but our understanding is so much better now than before, and now the challenge is maybe to understand individuality of the patients more than understanding general mechanism. And that, like this is also a really I like it a lot because when I was talking to Professor Gattinoni, he was always laughing to people that think that a single pill is going to solve problems by intensive care patients, because like they say, of course that did not work in the trial, but because we need to subdivide in more subpopulations and more subpopulations, and after you come to the individual patient, that is at the end the aim of medicine, and simply recognizing that there are lots of mechanisms, but at the same times the individual physiology is actually really heterogeneous, and one thing that does not apply to all patients in general. I like it a lot. And do you have an idea in mind? Do you have something that you see at the horizon that you think that is going to be revolutionary for intensive care? You think that is something at the horizon that you say, well, if I need to invest €10, I'm going to invest into this idea just for fun?
I think that one of the chances we have is to find out as early as we can that the treatment we are providing to the patient will lead to damage. What do I mean? I mean that maybe in the future we can get some biomarker, some very earlier sign that give us the chance to see that, for example, non-invasive ventilation will proceed to ARDS, or non-invasive ventilation will be fine for that patient. I think that this can be a chance to modify the prognosis of, in this situation, the ARDS, because let's say that even the COVID, we saw patients ventilated with non-invasive ventilation doing good, doing well, and others just deteriorating. Why they behave in this such a different way? We don't know. I think that just making research and looking for sure phenotypes or biomarker can make a difference.
Thank you. So we will have just to wait to see. But if I can ask you a really tricky question, so if you had to summarize to a young resident maybe that has no idea of what RDS is, what is the baby lung and why it is so important, and we should keep in mind that our patient might have this, and how would you do it?
It is not simple, but let me try to summarize that we don't have in critical care a single rule is not going to be applied to all the patients. And baby lung is the clear demonstration of that. I mean that what was thought to be generalized, homogeneous, what we see in chest X-ray, it's homogeneous. In the real world, it is not. And it is very different from one patient to the other patient. So if we are going to apply the same rule for all the patients, we are going to get damage. If the real power of this discovery was that it showed with the right way to see the lungs with a CT scan, we realized that what we thought it was homogeneous, it was not. And that was the very important discovery of the lung.
Professor Fumagalli, I thank you really, really a lot for the participation in the podcast. I think that talking to you, and I know that you are now freshly retired, let's say, and so you are somehow indirectly a carrier of by definition, older knowledge. But I think in this older knowledge, there is a lot of wisdom. And I think for all the listeners, it's really incredible to understand how difficult was the path to understand better the baby lung, but in general, how complex is in general to understand what is going on in the human body, especially in the context of ICU. So I thank you really, really much for this contribution, and I hope to see you soon somewhere in Milan.
Thank you. I hope to be to respect to fulfill your expectations, and I hope to see you soon.
Thank you, Professor. Thank you, Mattia. So I think we have come to the end of our podcast. For those of you that have not heard the first episode of Pathophysiology Stories, you can find it on our Spotify channel or on the YouTube channel. And also, I would like to invite all of you to follow Connect on the social media so that you can get updates on the further coming episodes. So thank you again, both to my co-host and our guest, and thank you for listening. Goodbye.